I think I can only see her if she joins.
Oh, right. I hear you. Okay.
Let's see. Candace is here.
Yeah, Hasina is in the weight room.
Perfect.
Hello.
Hi, Dr. Zena.
Hi, Alaska. Is Anne's probably
Hi.
waiting to let in. Hi, Jane. Anne's
And
probably
we used to do a double back to back. I'm just gonna hide and leave you to it. Sorry.
I don't
Solid.
see Anne in the attendees.
no
So
problem.
Yeah.
There were a number of the students from the tutorial who wanted to attend, so I'm not sure if they're in, but maybe we wait for Anne before we let anyone in.
there is someone who's joined with an iPhone name, so I'm unsure that could perhaps be her.
Just write to them and
Before-
ask them if it's her. You can DM people. I can't see it, but you can.
Correct.
I'm be surprised if she's late for her own JC.
Yeah, please. No, that's not her.
Iona's there.
I suppose I think we need to wait for Anne before we let people come in.
Yes.
See.
Hello?
Hi, is that Anne?
Yes, but I can't. Okay. Hi, how are you? Yes, I've been patiently waiting.
Oh no. Okay.
Can you
So
see me? Because I had to just unmute myself.
no, we
But
can't see you.
Yes, I can't seem to, which doesn't make any sense because I have the camera on. Let's see. But even like the chat,
Mhm.
I can't even make a little chat. Oh, well, that's why, because the host says disabled attendee chat. But why is it I can't use the camera? But this is not because am I allowed to show my slides or no?
Yes.
Yes.
Yes. Yeah.
Yeah, but the feature where I can do that, or share, isn't there a share screen button?
Yeah.
Yes, share screen.
But
Why do I not
you'll
see
have to
that?
be made host first or co-host.
Oh, is that why?
Yeah. So Laska, you have to make Anne co-host and then she can share. But we can't see your video either.
Yeah, that's the problem. I don't know why. I
Let's
did
make you
enter through
co-host.
my work computer.
So, Anne, can you see the little icon that says video at the bottom left next to audio? If you click on that, it should.
Yeah, you would think I would see that, but it's just the microphone, the mute, and there's no video button. You know how you could change your background and blah, 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 blah. I don't
Yeah.
see that at all.
I'm trying to see on my side, but it's not allowing me to give Anne any access to
But
be
what
a
I can do is Alaska, can you share Anne's slides?
Sure.
And then the only problem is we're not going to see your beautiful face, Anne. Do you want
Oh, no, but
to
that's not
exit?
terrible.
Do you
Okay.
want to exit and come back in and try again?
Yeah, I can
So
try
it
that.
isn't-
Maybe if I am signed in as a co-host, that would help. I don't know if that
Well,
changes. Because I don't
yeah,
see my little video thing next to the microphone that shows, if you want to change your background, you want to blur the background, that whole thing. It's like missing. Or then what is that? Are people already on this line? Should I just then present?
Yes, they do seem to be. Yes, there's several people
Okay.
that are
So what I'll
commenting
do is I
there.
apologize. Then I'm just gonna go ahead and just
Peter's
lock
saying,
up.
so Peter's saying the same thing. No one's able to There's no video settings for anyone.
Oh, good. So I'm not the crazy one. Okay,
And
thank you.
unless they're a co-host and I make them a co-host, like Hasina is a co-host, so you can see her, then you
So
can see their
you want
screen.
to just make Anne a co-host?
I'm unable to do that. It's not allowing me to do
If
that.
you remove me, can you remove me and then try Anne?
Let me see. No, that would just remove you from the whole Zoom.
Oh, okay. So I think the next best thing is that we share your slides, Anne, and then you present incognito. Sorry, I don't know what's going
It's
on.
okay.
If anybody has any idea, it seems like this is the same for everybody except us.
Well, I get to see your beautiful face, Hasina.
Oh, I was so hoping to see yours.
It's been a while. Oh my gosh. We graduated not too long ago, but so much has happened. Now I have a second child in college. My third child's about to apply this summer. It's
So I'm
just
gonna ask Laska, please let everybody in, and then we can, because I think we're live, and so we're just gonna jump in.
All
Okay.
attendees are here.
Okay, so can
they
we
can
start?
be
Because
in.
I can't see, I don't know what's happening today, but I can't see who's here. I think it's some kind of tech issue that we need to solve so we don't do it this way again. So hi, everybody, and thank you for your patience. This is a very interesting topic, and I have the pleasure of introducing Dr. Anne Park. She's a highly respected FACP, PNS, ABOM. She's a highly respected physician with board certifications in several key areas of health and medicine. She is a fellow of the American College of Physicians, reflecting her expertise in internal medicine. So a fellow colleague of mine, I love that. As a certified physician nutrition specialist, Dr. Park has advanced knowledge in nutrition and its role in clinical care. Additionally, she holds a certification from the American Board of Obesity Medicine, signifying her specialization in treating and managing obesity. She's known for her integrative approach to healthcare, combining nutrition, weight management, and general medicine to support patient wellness. So she has chosen a very interesting topic. We all, Anne, talk about the DASH diet. We know that our colleagues in the hypertensive clinic, they have no problem saying, since the patient has hypertension, right, DASH diet for you. Anne's asking, can we do better? Over to you, Anne. I really look forward to this talk.
very good. Thank you so much, Hasina. Welcome and thank you to this talk. I really appreciate your time. So my name's Ann Park, and I'm an internist, a primary care doctor, and also very proudly certified as a nutrition network practitioner. And today I would like to share with you everything I was able to learn about the DASH diet, because we internists, we recommend DASH diet all the time, not exactly understanding what we're actually telling the patient. And we also, very easily recommend a patient, oh, okay, just eat a low fat diet. Again, not understanding exactly what we're doing and what we're telling the patient. And so all this stuff comes into play. So next slide, please. Great. So we're going to be talking a lot about the continuum of how we even started with the DASH diet. It was a study done, it was a control feeding study done in 1997. And even now we still hold on to it. So it's just, some thoughts I encourage you to have during this presentation. Why we hold on to a study. It could be a good study from 1997, but perhaps it needs to be retired. So I compare it with other diets. And if you can't tell when you see the DASH diet, but when you dig a little deeper, you recognize it's a high carb, low fat diet. So in the realm of metabolic health, and we're all like-minded people here, offering a high-carb solution for hypertension is problematic. As we down titrate the carbohydrate, we can see both the blood pressure improves and also we get these wonderful metabolic health benefits that I do not see the DASH diet offering. Next slide, please. So 2025, I'm not sure if everybody here is familiar with the US News and World Report, but they publish even stuff like best colleges, best engineering program, best hospitals. And I work for a huge hospital network in the New York, tri-state, New Jersey area. And usually they're on that list. So it's just, I don't know if it's just paid advertisement or I'm not sure what it is, but basically, according to the US News and World Report, the DASH diet pretty much won everything, got #1 best for high blood pressure, for pre-diabetes and all that. It did lose out to the Mediterranean diet, though. It came in #2 as the best overall diet. Next slide, please. So this is basically what the DASH diet looks like. Currently, because now it's 2025, we do reference it as like -1 and -2, with the distinction of -1 limiting your sodium to 2,300 milligrams a day, and then -2 is even tighter, 1,500 milligrams a day. And the emphasis of DASH diet is restricted total fat, no more than 20 to 30% of your total daily caloric intake. Lean protein, they allowed about 6 discrete servings of 1 ounce portions. So what is all the hoopla about the DASH? Basically, the authors were offering the DASH diet as a possible alternative to drug therapy altogether for stage 1 hypertension, which is a systolic usually in the 130s, like 130 to 139, and diastolic 80 to 89 range, and even offer the DASH diet as possibly using it to delay medication initiation. Next slide. So what exactly is the DASH? It's not, if you read deeper, it's called the DASH, but the impact of dietary patterns on blood pressure. So what they did was they compared basically 3 different diets. It was a controlled feeding study, meaning they provided all the food. They basically had a larger population, about 1,000 or so, and then some patients don't qualify, so they dwindled down to 459 patients. 133 had hypertension. 326 patients in the study did not have hypertension, and this study lasted 11 weeks. The first 3 weeks, everybody got a controlled diet. Controlled diet meaning the standard American diet. We call it SAD, the standard American diet. And the following 8 weeks, the patients were randomized to 3 different diets. Either you receive the controlled diet, which is this standard American diet, or you receive the same buffed up with a little bit of extra fruit and veggies, or you got the traditional DASH diet. In this study, they call it the combo diet. You got the fruit and veggie, but it was different from the standard American diet in that you had lower fat. So they put in lower fat dairy and they dialed down the total amount of total fat, specifically bringing down the saturated fat. Patients were given the option for 2 extra packets of salt to use at their leisure. Alcohol was limited to twice a day, and caffeine, you could have up to 3 servings a day of caffeinated beverages. They were weighed every day. On the weekends, they didn't get weighed, but Monday to Friday, they were weighed every day. And I have a little picture of the cookie there, because to avoid weight loss as the reason for blood pressure improvement, because we know you lose weight, your blood pressure gets better. So any internist will tell the patient, just lose weight and your blood pressure gets better without giving a solution. They supplemented these patients with 100-calorie cookie or muffin packets. So they tried to eliminate the weight loss as an advantage. And hypertension patients, just mind you, had stopped all their medications before the study. All right, so they try to create an equal playing field. And the salt cap, the max cap in this study was actually 3 grams a day, even though now it's evolved into -1 and -2 with stricter sodium levels. And potassium was about 4,700 milligrams. And I mentioned that because, potassium and sodium are bosom buddies, right? They travel together. So, in aldosterone and all that other stuff, we always like look at those together. So the standard American diet macros, just to have that as a reference, we're talking about 15% of daily calories from carbohydrate, fat 35, and the protein was 15%. And the macros for this DASH, the original DASH study, carbohydrate 56%, fat 25.6%, and protein 17.9%. So the fat went from 35% down to 25.6%. So we would say about 10%. So just by looking at the macros, you can see that the DASH diet is higher in carbohydrate and lower in fat than the standard American diet. Because anytime you manipulate the carbohydrate level up or down, you're also manipulating the fat content, the fat and the carbs. They're reciprocal of each other. Next slide. Okay, so what did the DASH diet show? The primary outcome was improvement in diastolic blood pressure, and the secondary outcome was improvement in systolic blood pressure and just overall blood pressure in the ambulatory setting. And just to let you know, when we titrate medications for a patient, we don't base it on the blood pressures in the office because we make the patient nervous. It's like they have to get parking and all this stuff, so they come in stressed. So we don't base it on that. I really encourage my patients to keep a log at home, and that's actually where you see the fruit of your labor, how their blood pressures are improving from home. So that's why, just to give you that distinction, this is what it means to say ambulatory blood pressure, because that's the real blood pressure, not the one in the office. So a unique thing that it just kind of stood out to me, considering it was a feeding study, the authors reported that they had nearly perfect adherence to steady foods with no report of any non-steady foods eaten. And, between you and I know, that's hard to measure. You have to take the study patient's word for it. But it was a first paper I ever read where the authors were so confident the patients did not eat any non-steady food. So I just found that very interesting. And they did, as with any eating study, they checked the 24-hour urine excretion, because this is really kind of a reliable, it's cumbersome, but it's a reliable way of checking to see that, okay, the patient really is eating just from the diet. So they'll always measure potassium, sodium, magnesium. In this study, they also added phosphate, urea, calcium levels. And interestingly enough, the patients who got the DASH diet, they secreted the most potassium in the urine, and also urea and phosphate, and also they secreted the lowest amount of sodium in the urine compared to the others, which I found very, very interesting. And already, if you know anything about the renin, angiotensin, aldosterone pathway and stuff, it's already making me think about aldosterone. When you're secreting less sodium and less sodium, but then also less sodium, but then also secreting more potassium. We already think about that. Next slide, please. So follow-up reports of the DASH diet, because they just basically measured blood pressure. They didn't talk about triglycerides or HDL or anything like that. Subsequent to that, there have been a bunch of subsequent studies following up on the DASH diet trial, all consistently showing lower LDL cholesterol and lower blood pressure. So my question to you all is, would you expect higher HDL, lower triglycerides, lower fasting blood glucose, an improved HOMA-IR score, and improved CRP levels with any high carb, low fat diet? Would you expect that? So the lack of improvement in HDL and triglycerides already tells me the patient's eating more carbs than they can handle. So even a practicing internist like myself, I don't need to do expensive testing. I follow the triglycerides and the HDL, which is very telling in a patient. Next slide, please. So we now have two DASH diet variations. The OmniHeart study and the high-fat DASH diet. Next slide, please. The OmniHeart diet was lower in carbohydrate, 48% kilocalories versus the DASH of 58%. Patients were randomized to 3 different diets. Either you went up higher in the fat, and it mimicked basically the Mediterranean diet, or you went up higher in protein. And this is all at the cost of carbohydrates. So if you're going to drive down the carbs, then you're going to increase either the protein or the fat. That kind of makes sense. It was rolled out over 19 weeks, and it gave more flexibility because a DASH diet, can get monotonous and whatnot. And we all know in clinical practice, you could say one thing, but if it's really not sustainable, or it's just, it just, after a while, if it's not sustainable, a patient's not going to do it. So this is when they try to make it more, appealing to the larger patient population. And it showed that even that dialing down of just 10% of carbohydrate from the DASH 58 to the OmniHeart 48%, that you started seeing better lipid lowering. So the systolic blood pressure came down for all 3, right? Whether it's a little higher fat, a little higher protein, or the regular DASH, and the LDL cholesterol got better. However, the DASH diet showed no improvement in the triglycerides whatsoever, which is very interesting. So this study concluded basically partial substitution of carbohydrate with protein and unsaturated fat likely led to further improvement to CVD, cardiovascular disease risk factors. So lower carbs equals better results. And so far, we've added in our brain that the DASH diet does not decrease triglycerides. So that's a very important point to make. Next slide, please. Now, the high-fat DASH diet is basically what it sounds like, high-fat. So they dialed up the fat intake by switching from the DASH is famous for low-fat dairy. Well, they swapped it out and swapped in full-fat dairy, which added 13% more fat. And of course, they had to decrease the carbohydrate. So that decreased it by 12%. And they eliminated fruit juices and sweetened beverages. I'll talk about that a little bit later. But it was the sugar that was in the DASH was really coming from fruit juices. It was a surprisingly significant part. And the blood pressure benefits were there with decreased triglycerides, and the caliber, the size of the LDL started changing. You started getting more pattern A, as we all understand it to be light and fluffy and not angry, as pattern B. compared to the DASH diet. DASH diet showed none of these benefits whatsoever. So again, you're starting to see metabolic improvement by dialing down the carbohydrate, even just by 10, 12%, already right there. It's like a free gift. It's a free gift. So next slide, please. I'm sorry, next slide, please. So at this point, it made sense on this journey. Well, okay, let's see what carb restriction does as a whole. How about other diets? With that, they weren't exactly, challenging the DASH diet, but what do we already know? So there was a huge meta-analysis. It took 12 randomized controlled trials, and they all concluded, yeah, you dial down the carbs, then you are going to get a cardiovascular benefits. The controlled diets in these studies ranged about 45 to 55% kilocalories a day of carbohydrate. As we know, just to review, OmniHeart 48%, high fat DASH 43%. The blood pressure and the cardiovascular benefits with driving down the carbohydrates to 40% makes a positive impact. And in this study, they define, because anytime you review a paper about diet and low carb and keto and all that stuff, it's really important to focus on how they define low carbohydrate, because some papers will actually say it's keto, but it's not. It's so high in carbs. But this particular meta-analyses took studies where they define low carb as 40%. So we all are kind of on the same page there. Otherwise, it gets a little confusing. Okay, next slide, please. So the American Diabetes Association in 2019 said some really important stuff. I feel it really, this was the year before the pandemic. It really, for me, the tide, it was a surprising a statement that they made. Reducing overall carbohydrate intake has the most evidence for improving glycemia and may be applied in a variety of eating patterns. Low and very low carb eating plans are viable approaches for select adults with type 2 diabetes who are not meeting glycemic targets and wish to reduce anti-glycemic medications. So in this study, they compared 8 diets: vegetarian or vegan, grouped into one, low fat, very low fat, Mediterranean, low carb, very low carb, the DASH diet, and then paleo. So the low carb, very low carb group, of course, they improved blood pressure. Of course, they had better glucose control. And of course, they lost weight. Hemoglobin A1C improved, HDL went up, triglycerides went down, and overall, they were able to reduce their diabetic medications. Now, the DASH, the ADA assessment of the DASH, also said an improved weight loss, okay, improved blood pressure, okay, hemoglobin A1C, and cholesterol level, but no change in triglycerides. They didn't say exactly which cholesterol level, but no change in triglycerides. And they concluded that the best diet for type 2 diabetes is the low carb diet and the Mediterranean diet. And even though a study is not specifically looking for hypertension improvement, when you look in the realm of metabolic health and diabetes and glucose control, hypertension definitely goes along with the territory. So it made sense for me as I was picking through the DASH diet to also look at studies, although the title or although the goal of the study might not have been blood pressure lowering. If they were in the realm of metabolic health and asking that question, can we do better? Does the patient do better if we decrease the carbohydrate? That it was worth reading it and then comparing it with somehow with the DASH. It made sense to do that. Next slide, please. It's kind of buried. It's not attached to the ADA consensus report, but when you Google and, just poke around and see what's out there, there's a supplemental PowerPoint slide quietly attached to the ADA 2019 consensus report. And it's called Research Recommendations in Real World. And the name of one of the authors stood out to me. Dr. Yancey works with Dr. Eric Westman at the Duke Lifestyle and Weight Management Center. And so I, piqued my interest. So I read further and I learned a lot from the slides, and was pleasantly surprised to see that these slides were, from the ADA, not openly, advertised, but it's out there. So the very low carb diet has been shown to be beneficial with the 5 metabolic syndrome markers: glucose control, hypertension, weight loss, HDL cholesterol, and triglycerides. The American Heart Association, meanwhile, and the NIH both continue to support the DASH diet over a low carb diet. The ADA does not officially promote, it just openly talks about it, but it doesn't officially promote it, but it does list it as a viable option. And in the slide deck, if you have some time and you read through it, and I put it in my references, it gives beautiful instructions and education to the layperson of what low carb diet and very low carb diet is, with the macros and the amount of fat, and mentions intermittent fasting, nutritional ketosis, and ketoacidosis, the keto flu, and all about deprescribing, all the benefits of that, and a bunch of really wonderful resources for the layperson, which I was pleasantly surprised to read something. And it's written in a way where I know I can, for my patient, I can happily just recommend it for them to read. Next slide. Now we come to Laura Saslow's study, the M-HERO trial. It was done at University of Michigan, and it was only the only study, as far as I know, that actually challenges the DASH diet against not just a low carb diet defined as 40% kilocalories a day, but a very low carb diet where we're limiting not even a banana's worth, because a banana is about 30 grams of carbs a day, but very low, 20 to 25 grams of non-fiber carbs. Because the authors of this study recognized that in the DASH diet, there was basically no carb limitation. So it was a 4-month study. Food was not provided, but they got a lot of support because they were measuring that as well. Did the patient benefit from coaching, social support, cooking lessons, plus or minus the DASH versus the very low carb diet? And primary endpoints were systolic blood pressure, hemoglobin A1C. Secondary endpoint was weight loss. As you can see, for the very low carb diet, systolic blood pressure improved more, 9.77 millimeters of mercury versus 5.18, and so on and so forth. So, and then you even lost basically almost 10 pounds more with carbohydrate restriction. All these little jewels and all these little gifts from carbohydrate restriction that you and I are very familiar with, but still, it's still something that remains an enigma within the general medical community. Next slide. So at Duke, they probed a little further, and Dr. Eric Westman, this is back in 2008, compared a low-carb ketogenic diet to a low glycemic index diet, because often those two things get very mixed up, right? It's not the same. It's just not the same on glycemic control. So the primary endpoint, of course, was improved hemoglobin A1C, and both groups did do well. Because, you know, with anything with patients, if you ask them to, you know, could you pay attention to what you're eating, that already is very helpful. Doesn't mean that that's the best solution, but that already, you know, because they're setting some boundaries and so on and so forth. So both groups did well. They both improved in hemoglobin A1C, their fasting glucose, their fasting insulin. They both benefited from weight loss. But we can also see that just by doing that, 5 patients actually stopped insulin. They were taking upwards of 50 units and 90 units. So that's a significant impact. And blood pressure improved, of course, in the ketogenic diet. There was higher improvement. Systolic dropped 16.6, diastolic 8, and the glycemic index counterpart decreased as well, but not as much, not as significantly. What stands out here is the glycemic index diet, the low glycemic index diet. They had no change in the HDL, no change in the HDL, which again, in the continuum of metabolic health, if you're not dropping your triglycerides and you're not increasing your HDL, again, that tells me the patient's eating too many carbs. And when we take a step back and kind of look at this after having learned what we already learned about the DASH diet, here, like the macros, it kind of looks like the DASH, the low glycemic index arm of this study. They look kind of like the DASH diet people from where I see. Next slide, please. Now we come to the Norwood diet. I didn't realize it was called the Norwood diet. In my mind, I always call it Dr. Unwin's diet, but this is the Norwood diet. It was a beautiful study done in the north of England, in the Norwood Surgery Primary Care Practice, where 154 patients with either had diabetes or they had impaired glucose tolerance were gathered together and given a lot of support and education. They were given a sheet about basically food rules, like don't eat this because it has a lot of sugar, things like that. And then they were given another sheet, a really powerful visual of the glycemic load. So you were able to see how many teaspoons of sugar was in your spaghetti or in your basmati rice or so on and so forth. So patients, I mean, this was just a lovely study showing real life. I mean, everything's fine and good in theory, but when you're in front of the patient, you need to be very practical. So seeing what Dr. Unwin and his team did, it really inspires me. When you dig a little deeper, the patients were given about 130 grams of carbohydrate per day, and they got group meetings, 90 minutes every month. So they got that support, and they were followed for 2 years. But the data was screened over that long period, 2013, like 5 years. Systolic blood pressure, of course, decreased on carbohydrate restriction. So did the diastolic blood pressure.
And are you there?
Hello?
Hi, we lost you there for a moment.
Do you hear me now? I'm so
got
sorry.
you now. No
Okay.
problem. You were just talking about, you said that for 2 years they were followed up, but the data, that's where we lost you.
Oh, the data, sorry. The data was collected from 2013 to November 2018. So it was a retrospective analysis, looking back, oh, what did we learn? But the patients ate the diet for 2 years. Yeah. And of course, the blood pressures were improved. There was noted improvement in triglycerides. Mind you, the DASH diet, the HDL and the triglycerides don't budge. And there was, of course, wonderful weight loss. And what was really important in the study, just like Dr. Westman's study, these patients benefited from deprescribing. So could you imagine as a whole group, all those patients, they were taking upwards of 163 medications, went down to 122. So that was calculated to be a lovely 21.5% drop in the medications. And there was a nice portion of the paper that explained possible mechanisms and so on and so forth, because we all know about hyperglycemia and then hyperinsulinemia, how it causes salt retention, and then the water, because the water follows the salt and your blood pressure volume goes up, so on and so forth. But Dr. Unwin, he brought something to my attention that I wasn't really aware of, or he explains it really well, where the SGLT receptor in the kidney actually is where all the sodium and the water is being absorbed. Well, it's one of the places. And so if you actually add a drug, because sometimes you don't understand the physiology until you give a medication and then you see, oh, this is how it works. So when we actively prescribe SGLT2 inhibitors to prevent the glucose and sodium reabsorption. So Dr. Unwin's point was saying, can we duplicate the benefit of osmotic diuresis by just giving the patient a low carb diet? Because the low carb diet will dial down the hyperglycemia, then dial down the hyperinsulinemia. And the less insulin you make, then you reduce the SGLT expression, because the body doesn't need it, because it's not going to make something it doesn't need. The more sugar you eat, the more it's going to express. You don't need it, then it makes. So this kind of makes perfect sense. And currently, the American College of Physicians that I'm a part of, they actively recommend adding a SGLT2 inhibitor to whatever medications that they already have, because there's strong evidence that it reduces risk for all-cause mortality, major adverse cardiovascular events, so on and so forth. So basically how it works is the blood coming to the arteriole starts dilating, and the efferent arteriole starts constricting. But the SGL2, and I know ACE inhibitors and ARBs also do the same thing, it helps you relax what leaves the kidney, so then the blood pressure comes down. Because if you're constricting the blood flow that's exiting the kidney, then you have too much pressure. You have too much it's filtering just too much. But if you release that, like the pressure valve, then the blood pressure comes down. So next slide, please. So I did change the order of my slides. So could we go to the one with the sugar slide, where sugar sodas and stuff? It's like all those sugar teaspoons. Oh, it's towards the end. Yes, yes. So we've all seen, variations of this table. So did you know 59% of the fruit intake on the DASH diet was from fruit juice? Sugary beverages reflect our modern diet, table sugar, glucose, and fructose, and worth further exploring. Studying the renin-angiotensin-aldosterone system, glucose polyol pathway, which I learned during the Nutrition Network certification thing, because I'd never heard of it before. So thank you to Nutrition Network. Fructose to uric acid production, more aldosterone, more insulin secretion are in alignment with better understanding metabolic syndrome. And so my observation is that it's not just about the hyperglycemia, and it's not just about the hyperinsulinemia. There's definitely more there. Next slide. And this slide with the title DASH diet and metabolic syndrome. Yes. I think it's, yes. The one with the big colors. The metabolic syndrome one above that. Yes, thank you. So there's a lot going on here, but in one bite, it shows pretty much what we need to know. So DASH diet is I've concluded, is the antithesis of metabolic health as a high carb, low fat offering endorsed by nearly every medical organization for blood pressure, hypertensive treatment. There's no published data, right? No published data has yet shown it can cause or worsen diabetes. Despite daily carb intakes of 55 to 58% of daily caloric intake. So this is a very high recommendation of, very high levels of sugar. We're talking 200, when you actually do the math and the calculation, kind of guesstimate it's average 2,000 calorie diet a day, 226 grams to 449 grams of carbohydrates per day, which is astronomical, completely out of control. The DASH diet is a metabolically flawed diet with no change in HDL, triglycerides, fasting blood glucose, increase in LDL pattern B, decrease in LDL pattern A. I'm unable to offer a high carb, low fat diet such as this to treat hypertension to any one of my patients. DASH does not improve the triglyceride HDL ratio, and so its highly touted benefit of decreasing LDL holds very little value, and it's completely irrelevant. Must we continue to recommend the DASH diet as the #1 best diet for hypertension? Next slide will be Dr. Reven quote. Yes. So we have a good understanding, but there is much more still to learn about the true cost of the sugar epidemic. Dr. Reven correctly identified the sugary diet as the key driver of insulin resistance and cardiovascular disease. The fact that an insulin resistant subject may not become diabetic does not mean that they suffer no untoward consequences. Indeed, an argument can be made that the more insulin sensitive an individual, the better off he or she is, and that the attempt to compensate for insulin resistance sets in motion a series of events that play an important role in the development of both hypertension and coronary artery disease. Banting Lecture, 1988, Dr. Gerald Reven. Can we go back up to the slide with the metabolic syndrome? Yeah. If you look there, it's clear to see, on the left, everything in gold, the increased triglycerides, decrease in HDL, abdominal adiposity, blood glucose, and hypertension. And you look behind it, inflammation, oxidative stress, prothrombotic state, getting blood clots, and so on and so forth, insulin resistance. I look at this and I'm thinking aldosterone. Aldosterone does all that stuff. So right now, I have to figure it out. But right now, people are asking, is it really the insulin that makes you secrete more aldosterone, or is it vice versa? Is it the aldosterone that makes you more insulin resistant? Very interesting question. And then I'm going to leave you now with the last slide. Yes. So in one study, adolescents were given soda. They measured their blood pressure and uric acid level. And guess what? In 15 minutes, both went up after drinking soda. So here's a housekeeping tip. The pH of soda, the phosphoric acid, is the same as vinegar. So it's been found to be highly, highly effective. So I encourage you all, stop drinking soda. Don't give your kids soda. Instead, if you have any leftover in the house, please use it to clean your toilet. And then next slide. Much for your attention. I'm open to any questions. Thank you.
Thank you very much. And this, I've sat, as you probably have, in hypertension clinic and all the different specialist clinics. I see you. Hi. Finally. Shall we stop share so we can see more of you? Laska, can you stop sharing? Thanks. Hi. Thank you so much. This was such an awesome and thoroughly researched comparison of the different types of DASH diets with a focus on hypertension. And I've sat in so many specialist clinics, and there's an academic meeting literally every week, more than one a week sometimes. Never have I seen a diet for a clinical, really critical chronic illness explained so beautifully. So thank you so much. I think many people know and have an idea of what the DASH diet is, but you have really demystified it. And so congratulations for doing that. So if you have any questions, put the questions in the chat box, please. But I wanted to say that, of course, I don't know what your experience is, but we know that the pathophysiology of hypertension for hypertension itself is linked with, so there's so many different mechanisms, this sympathetic nervous system, the depletion in nitric oxide, endothelin-1 stimulation, the renin-angiotensin-aldosterone system, the mitotic stimulation of growth and atherosclerosis, or from the insulin and the redox reactions. And when you look at like the SGLTs being prescribed, it is typical of the way things work. Someone studies or develops this one drug that affects just one receptor in this vast kind of pathological milieu and says it's going to do that. And so they present, the rep comes and presents this wonder drug. And now you get the drug, and now you're all trying out the drug. So probably the same for you.
Absolutely. I mean, how do you stop them from coming? Because they coax my front desk staff to bring lunch. But that's a story for another day. But again, as you said, Hasina, it's just it's like taking the plug and chug method. Oh, you're broken over here. Let's plug the hole over here. It's really an oversimplification of the complexity of how we heal, why we heal. And so it would be a disservice. And I always say, what a missed opportunity if you as a clinician don't know what you're talking about. When it's like really you're there for like 10 minutes. Well, I take too long because I talk too much with my patients. But if what a missed opportunity for you to give the prescription, but also say, what do you eat? What do you eat? Because it matters. And that opens up this opportunity of friendly conversation, just asking, checking in with the patient, and not how can I say judging, because that then you're dead in the water with the patient. Right.
Yeah. So, I mean, like when you look at the SGLTs, yes, they do a good job. Just like when ACE inhibitors first came to the fore for protection, renal protection in the face of long-standing diabetes, and everybody has to be on an ACE for renal protection. But I fear that, I mean, of course, we know the SGLTs have side effects like UTIs from the glycosuria and other things like ketoacidosis sometimes. But I fear that we take the same approach across with us to the ketogenic world, that how many people, myself included, are on different supplements, that when you overstimulate one pathway without food, not in its natural form, there was a study that showed, I think it was vitamin B12 and folate supplementation increased the risk of colonic cancer, colorectal cancer. So I think it's an approach that we all need to just take a whole, food approach, or take a whole person approach. There's a question, Anne, from Ada Ramos. What are the other causes of hypertension outside of insulin resistance? I have had a couple of clients not see much results in lowering BP on a low carb 3-month program. Interesting question.
Sure. I mean, one place I would look also is maybe going down the renin-angiotensin pathway to see if they're secreting, if they have primary hyperaldosteronism. Okay, that's one pathway. Number two, screen them for sure. Screen them for sleep apnea. Screen them for sleep apnea. Because a lot of these patients, obstructive sleep apnea, untreated, goes along with uncontrolled high blood pressure. And so a lot of times those patients, they're secreting more aldosterone, but it's also the whole picture. Usually someone with sleep apnea, but I've seen really tiny patients with sleep apnea. Weight's not always an issue, so I don't want to put that in there. Looking at them as a whole, asking them, what do you eat? How do you live? How's your fatigue level? All that stuff would be a good place to check. Also, then there's also the more complicated stuff like, are they secreting it? Do they have an adrenal tumor? Do they have like pheochromocytoma? Of course, all that other stuff. That's when, as an internist, I don't have the bandwidth to do that workup. I just send them to the renal doctor, the kidney doctor. Yeah, up in my neck of the woods in the New York, New Jersey, New York City area, I'm an internist, but I outsource endocrinology, cardiac, so that's like, I know that's not, in middle America or somewhere else, I know the private care doctor does everything, but in my neck of the woods, people demand they have their own everything,
Hey, that's nice for you. In our neck of the woods, you have to do everything to figure out who's going to figure out the problem. And so I like to explain to people that there's so little we know. So we call it essential hypertension because we don't know yet what the cause is of the hypertension. And, it'll probably be called insulinemic hypertension or something like that. But there's this pie chart that we learn in internal medicine about when we're doing a deep dive into hypertension, and then we've got the renal causes, the arterial causes of the renal arterial causes, the endocrine causes, the genetic causes, and then there's this big, like 70% or so of the pie chart that is essential hypertension. It is hypertension, don't know why. So I would say also that I don't know, Ada, if you're a doctor or a nutrition advisor, but blood pressure is a big problem. It is the silent killer. It's not called a silent killer for nothing, because I like to explain to people that when you feel that blood pressure cuff on your arm tightening and it's really uncomfortable, that's what your blood pressure is, that the machine's trying to measure. That's what's happening inside your body. You just can't feel it because you don't have nerves to pick it up. So living with that 24/7 is detrimental. And so that patient would, even if it's not that high, should see a physician to just get a thorough workup. I don't see any more questions coming in, but I have a question for you, Anne. What do you do with your low carb patients who are hypertensive with electrolyte supplementation?
So I always ask, well, what do you eat? How do you work? Because sometimes, if I have school teachers or people, other physicians and whatnot, sometimes they don't have time to drink water.
Yeah.
Right. Or then if you're a bus driver or a truck driver, you just don't. So that's why you always have to ask. You need context. So depending on that, I tell them to supplement, but sometimes it's like, what do you mean? I'm not going to eat salt. So I say, sprinkle in your food, or some practitioners I know do soy sauce, or they add it through somewhere else. Or I'm a big fan of bone broth. I say if you can make it, do it yourself and sip it, because it's like chock full. It's like nature's Gatorade, basically. So if you could do that. And then I remember reading Obesity Code by Jason Fung, and he said, yeah, take your chicken and the bones or whatever and put 2 tablespoons of apple cider vinegar, and it leaches out everything because it melts everything and all the goodness comes in. And that costs nothing, as opposed to buying, prepared bone broth. As you know, it's so expensive. Food cost, it's so expensive. And so things like that, I tell them to be mindful. But, this is just food for thought. You know how we always blame the salt, but we say, don't blame the salt. Maybe it's the sugar, like, you know, don't always blame the salt. But, you know, if you don't have salt, you die, right? So then I was like, you know, then I read stuff that said, you know, don't simplify and just think it's through insulin, and it's just simplified where it's the hyperinsulinemia that makes you retain the salt. Because there's some studies, like there's a group of patients observed, there's a study in New Guinea, Papua New Guinea. They eat a high carb diet, but a high carb, low salt diet, which is very interesting because the basic food is the yam. So it's a high carb. So they walk around with very high aldosterone levels, but they don't have all the cardiovascular damage.
Right.
So the theory is that aldosterone looming in the background, aldosterone and insulin are very much baked in together, which I want to further explore. I'm like, that's interesting, right? And so what aldosterone is actually the stuff that insulin kind of gets blamed for, but I'm trying to further understand. I don't know which is which. The aldosterone sets the stage for all the cardiovascular, the intima, the atherosclerotic damage, the inflammation, right? All that depleting the ATP in the mitochondria, causing blood clots. That's the stuff that's actively doing that. And what happens is then because of that ravage of the damage from hyperaldosterone secretion, then it actually makes you less salt tolerant. So when you take patients, like if I were to feed this patient now salt, right, then they would then accelerate with kidney disease and cardiovascular disease and whatnot. It's very interesting what's out there. They're saying that the aldosterone or diet that makes you hypersecrete like uric acid, we could even call this uric acid hypertension, right? Hyperuricemic hypertension, right? All that uric acid, because uric acid makes you secrete more aldosterone, right? All that stuff, that rabbit hole you enter, and even the teenagers, within 15 minutes of drinking soda, their blood pressure went up, their uric acid went up. There's something there.
So what was the insulin in that group of people?
I'm sorry?
What was the level of insulin in that group of people?
Well, they didn't talk about that.
Yeah, because I would be interested in that.
Yeah.
Yeah. Because
Yeah.
when you think about primary hyperaldosteronism, then you would just be getting a lot more, you know, there's a lot of blood pressure issues, and we'd be seeing more of that. And I haven't really, you know, it's one of the, with unexplained hypertension, it's a core test, and I haven't seen that, but interesting points. We are over time. There are no more questions, but I really love this talk, and it gives so much more confidence when you're prescribing a low carbohydrate diet or very low carbohydrate diet, like the Norwood diet, to patients with hypertension. I love what you mentioned about the visuals being very helpful to explain to the patient the effect. Any closing words before we say goodbye to everybody?
I just want to say thank you so much. It was a very hard journey putting this talk together because I changed my topic like 15 times.
I'm
And
very glad you chose this one.
why are you asking why I chose this one?
No, I'm saying I'm really glad that you chose
Oh, wonderful. Yeah, because you know, at the end of the day, you want to just ask a simple question, and that's usually the most practical thing rather than getting all, you know, too much. So I'm glad that I learned so much about, you know, this, you know, what I'm recommending and not recommending. I feel good about it. And I'm just so grateful that I had this chance to share with you all, to share. And thank you for your time, because I know you're all so busy. So I really appreciate your time.
No, thank you so much. And this should just encourage everybody. I really love it that when you go to what are the questions that plague me that I don't know enough about, and I want to just get a lot of clarity, and it really helps the network to grow. So thank you so much. There was a comment about, I don't see the comments coming in about me swaying. I'm so used to it now, I haven't realized it. It's an under desk bike. It's just a plug to, I know Peter's on. We've got an exercise module. So we talk about the dangers of sedentary behavior. So we have to walk the talk, or in this case, cycle the talk. So make sure that you're not spending too much time sitting, people. So hopefully we can normalize the sway in these live sessions. Thank you so much, Anne, and thank you everybody for joining us. And we will see you again next time. Bye.
God bless. Thank you. Bye.